Dr. Koray Erdogan, Istanbul. I want to thank to the society. I'm honored to be here. I want to show all details of my extraction technique as a case presentation. History. 25 years old, smoker patient without any health problem and just taking finasteride for 2 months with no side effect. His maternal uncle is Norwood 6 and he has similar hair history in his family. He has started to lose his hair when he was 18 years old. It's visible that he will continue to lose his hair and probably he will be Norwood 6 in the future. As a first step, I wanted him to take finasteride 1 mg per day to stabilize his hair loss and minimize the possibility of shock loss after the operation. I believe that finasteride works also for recovering the density of donor in the first year of the surgery. Superior occipital. 119 follicular units and 269 hair per square centimeter. Average hair per follicular unit is 2.26. Inferior occipital. 114 follicular units and 268 hair per square centimeter. Average hair per follicular unit is 2.35. Temporal area. 88 follicular units and 195 hair per square centimeter. Average hair per follicular unit is 2.16. Total donor area is 224 centimeters square. Average density of donor area 107 follicular units per square centimeter. Total follicular units of donor area 23,968. Total donor capacity of this patient is 8,388, which is 35% of total donor follicles. Determination of total donor capacity. I believe that this is the hardest and most strategical decision of a hair surgeon. I changed many times my first plan when patient came for the second surgery. I always decide according to the density of donor. If density is between 70 and 80, my harvesting is 25% of total donor follicles. If between 80 and 100, 30%. If between 100 and 120, 35%. More than 120, 40%. For the first operation, because of the possibility of miniaturization, I never harvest more than 20% of total donor follicles. Surgery strategy. His total donor capacity is 8,388 follicular units. His family hair loss history is Norwood 6, but he has just started to use finasteride 2 months ago. I am planning 4,000 grafts as a first operation and wait for 1 year to see his regrowth rate and ability to go with finasteride. We will start with extraction of 2,000 grafts from his left donor side for his front line. The other day, without any resting day between, we will continue with another 2,000 grafts from his right donor area for mid-scalp and crown. ES extraction technique. Patient sitting, surgeon standing position. Versi hand penetration by punch. Sequential harvesting by other hand. Why sitting position? One of the biggest problems by FUE is non-homogeneous donor harvesting. By sitting position of the patient, I can easily balance my extraction separation and every follicle has same difficulty to reach. Patient comfort is also better when comparing prone position. They can breathe better and watching TV during the extraction period. My partner and assistant Dilek offered me to use my left hand by punch and right hand to pull up the grafts. This may look like harder at the beginning, but by practice you are starting to get benefits by speed and graft quality. Because by sitting position, all of the follicles are in their original anatomical position without extension of neck. I am using a less sharp punch with semicircular incomplete rotations. Right hand to control pointing to the follicle by punch into the midpoint of circle. First penetration is perpendicular to the skin through the epidermis, then changing the direction of punch up according to follicle angle. Our average speed is changing 600 to 800 grafts per hour, depending on patient skin type and graft quality. But for a short period of extraction, I wanted to show you how you can be fast by DES extraction technique. During the extraction, another team is counting and separating grafts according to their hair number. Incisions. I prefer 0.8 or 9 mm blades with coronal incisions from 45 to 55 degree angle to the surface. With coronal incision, implantation is harder, that's why I choose wider blades. But as covering the graft like a pocket, I believe result is more natural and coverage density looking is higher. Also for the sides, it works better and the direction of the graft cannot change by implantation technique or edema after operation. Implantation. For first 300 incisions, we need 300 single follicles. As I don't prefer to implant partial transected single grafts, we use 0.6 mm punch for original single follicles. Sometimes it looks like single, but when extracted, you may realize unmature follicles together. Every graft has its own site. During the implantation, we are trying to find original direction of each graft, how they extracted. Sometimes we change the direction of implanted graft to the original site in recipient area. Keeping follicles in hypotonic solution till implantation helps to minimize the volume of the graft. With smaller size, easier to implant with single pincet. Main point, not to damage hair bulb. No dissection, no trimming. We just implant all grafts 1 mm higher to prevent contact inhibition of epidermis. Surgery statistics. Total number of grafts 4002. Total number of hair 8707. Average number of hair per graft 2.17. Original number of hair per follicular unit 2.25. Overall transaction rate 3.6%. Average density 35 grafts per square centimeter. Possible remaining capacity for future operations 4,386. 2 days before coming to San Francisco, I called the patient and wanted his 5 months photos after the operation. These are before and after 5 months photos. Although finasteride was recommended, he started to take it but stopped after 15 days because of what he read on internet forums about persisting side effects. Unfortunately, this becomes to happen more often with my patients since 2 years. Hi. After FUE, I believe that the definition of hair transplantation is also changed. The new definition is homogenizing hair all over the scalp, not just in the recipient area. Thank you.